Good morning, everyone. Happy Friday. It's my grandmother's 97th birthday, so it's a special day, and I knew Lily would want to present on it. I think this might be the first time that Lily is presenting to the High Rounds group, I believe. This we seem to have as I mentioned last week, we're in a fellow theme. So I think this is our third fellow in a row presenting. And Lily is going to be presenting on something that I think a lot of us have some more expertise on. But Dr. Lily Ostrer is an adult and pediatric ID fellow at UCSD and Rady Children's Hospital. She has a strong interest in HIV, substance use disorders, and perinatal infections. She's been doing research and learning infectious disease modeling under the mentorship of Dr. Natasha Martin over the past year as a trainee on the Hope T32 grant. Um, that's all I have for her bio. Lily's wonderful. You're all in for something good today, and it'll be nice to see what she's been up to. Lily, I'll turn it over to you. Both me and Dan sort of keep an eye on things in case one of us ducks out, and I'll give you the 8:45 warning.
Okay, sounds good. Thank you very much. Thank you for giving me the opportunity to present today. Um, I'm going to be talking about long-acting antiretroviral therapy among people with substance use disorders, and looking at some of the work that I've done over the last year in clinical outcomes and epidemic modeling. I don't have any financial disclosures. Um, just a brief overview of what we'll be talking about today. I'll be giving some background on HIV among people who use drugs and long-acting ART. Um, and then I'll be talking about the two of the projects I've been working on. One looking at 96-week clinical outcomes with long-acting ART among people with adherence challenges and substance use disorders here at the Owen Clinic at UCSD, and then my primary project on modeling the potential population impact of scaling up long-acting ART among people who inject drugs in India. So just some background among people who inject drugs and HIV. So we know that people who inject drugs are at higher risk for acquiring HIV and face unique barriers to engagement in HIV care. And among the 14.8 million people globally who inject drugs, it's estimated that 15.2% are living with HIV. And we know that there are major gaps in the care cascade for people who inject drugs, both in the US and globally, and that ART use is suboptimal, and that long-acting therapies can potentially increase ART uptake, viral suppression, and engagement in care among people who inject drugs. So when we talk about the care cascade, this is the cascade of being diagnosed, linked to care, retained in care, and then virally suppressed. And we know that people who inject drugs are less likely to be linked to care and virally suppressed than the overall population of people who are living with HIV. This is CDC data from 2022 to 2024 that shows that people who inject drugs are less likely to be linked to care within 1 month of diagnosis. So 76% among people who inject drugs versus 82% overall. And then people who inject drugs are significantly less likely to be virally suppressed within 6 months of diagnosis. So 54% among people who inject drugs versus 69% overall. And then I won't be talking about PrEP today, but I just thought it was important to mention that PrEP is significantly underused among people who inject drugs. And here in San Diego, we know that the data also shows that people who inject drugs are less likely to maintain viral suppression. So this is some work that was presented by some of our colleagues at CROI in 2024, that essentially shows it's a Kaplan-Meier curve, essentially showing that people who attained viral suppression after diagnosis and then developed rebound viremia, or did not continue treatment, that people who inject drugs were most likely to experience rebound viremia. And after about 6 months, nearly 40% of people who inject drugs are not suppressed. So we know that there are significant gaps in care for people who inject drugs here in San Diego as well. So, as I mentioned earlier, long-acting treatments are potentially um, could potentially benefit people who inject drugs greatly. Um, and I know many of you know this, but just as an overview of the two currently available long-acting ART regimens, so cabotegravir rilpivirine is an intramuscular injection that's administered every 4 or 8 weeks, and it's a complete treatment regimen for HIV for people that have no known history of resistance to either cabotegravir or rilpivirine and no chronic hepatitis B. Lenacapavir, on the other hand, is a subcutaneous injection that's administered every 6 months, and it's part of a treatment regimen for people with multi-drug resistant HIV, but is not a complete treatment regimen on its own. And we know that these long-acting regimens can address several challenges related to social determinants of health that people who inject drugs face that can impact adherence. Just some examples are decreasing the pill burden, avoiding loss or theft of pills, and decreasing the stigma associated with unintentional disclosure. So the initial studies that were done, the initial trials that were done, that led to the approval of long-acting cabrolpivirine excluded people who use drugs. So I know many people are familiar with the initial randomized controlled trials. And these trials only included people who achieved virologic suppression on oral ART, and they all explicitly excluded people with substance use disorders. And they all demonstrated non-inferiority of switching to long-acting cabrolpivirine from oral ART. So why were people who use drugs excluded from these trials? These are a couple of postulated reasons, and there are likely others. Non-adherence was a big concern. So with long-acting cabrolpivirine, we know that um, unlike oral ART, where there's rapid clearance of the drug once it's discontinued, there can be a long pharmacologic tail and exposure to less concentration of drug over time, which can lead to resistance. And there are concerns that if develops to both cab and rilpivirine, there could be loss of two significant drug classes that make up the backbone of many ART regimens. And then there were also concerns about initiating long-acting cabrolpivirine in people with detectable viremia. So so cabrolpivirine obviously is a two-drug regimen. There are a couple of other two-drug regimens that are available, but these are mostly used in people that are either already suppressed or have lower levels of viremia. And neither cab nor rilpivirine are considered to be drugs that have a very high genetic barrier to resistance, and so there are concerns that this could also lead to drug resistance. And then, of course, within the context of a clinical trial, there's the desire to optimize the patient characteristics to produce a positive result, and that retention and follow-up in these trials was a major concern. So, despite the fact that we have limited trial data, there's growing recognition of the importance of expanding these regimens to some of the people that could benefit really greatly from long-acting injectable regimens. So there's actually been kind of a shift in the guidelines over the last couple of years to include people either with viremia or adherence challenges, despite the absence of trial data. So the initial FDA package insert indication for cabrolpivirine was as a switch option for people who were virologically suppressed on a stable oral ART regimen and had no history of treatment failure. And the DHHS guidelines initially kind of mirrored the FDA indication, and then more recently have been updated to include long-acting cabrolpivirine can be considered on a case-by-case basis for those with persistent viremia. And then the IAS USA guidelines went a little bit further in 2024 when they suggested that long-acting cabrolpivirine can be used in people with viremia who are unable to take oral ART consistently. And then for the first time, the WHO guidelines have also included long-acting cabrolpivirine as a switch option for people who are virologically suppressed on oral ART. And so hopefully this reflects the increase in global availability of cabrolpivirine. And just to note that the guidelines changed in part due to data that mostly was published by the group up at UCSF on outcomes on cabrolpivirine in those with viremia. But there's still very limited clinical data in those with a history of adherence challenges. And that's one of the gaps that some of the research I've done is trying to help close. So the guidelines changed, or guidelines have kind of been slowly changing over time. But actually, just earlier this year, we did get some trial data when the results of the Latitude study were published. So probably many of you are familiar with the Latitude study, but I'm just going to discuss it briefly. So, Latitude was a trial that was conducted among people with history of viremia or with difficulty with adherence to oral ART. So they defined their eligibility criteria as people that had a viral load greater than 200 copies per ml or were lost to follow-up in the prior 18 months, despite having a prescription for oral ART. And it was a two-step trial. In the first step, um, people were given what they called enhanced adherence support, as well as conditional economic incentives to achieve viral suppression on oral ART. And then those who achieved viral suppression were eligible to move on to step two, where participants were randomized to either continue oral ART or to switch to injectable cabrolpivirine. And their primary outcome was regimen failure, which they defined as two consecutive viral loads greater than 200 or treatment discontinuation. And then over on the right, you can see some of the inclusion or some of the population characteristics of those who are included in the trial. And it included 28% that used amphetamine or methamphetamine, and then 11% that used opioids or methadone. And so this indicating that this trial was inclusive of those with active substance use. Um, so the results from the Latitude trial were pretty incredible. It showed that in the long-acting cabrolpivirine arm, the rate of regimen failure was 22.8% versus 41.2% in the standard care arm, and these results were statistically significant. There were 5 virologic failures in the long-acting cabrolpivirine arm, which were driven by drug resistance, and there were 29 discontinuations overall. So the trial actually stopped randomization early, given the significant findings of superiority of cabrolpivirine in this population. So the trial concluded that long-acting ART demonstrated superior outcomes compared with oral ART among people with history of adherence challenges. And some of the limitations of this study were that they used conditional economic incentives, which may limit real-world applicability. And it was also designed to initiate long-acting ART in people who were virally suppressed, and not among those with viremia at the time of switching to long-acting ART. So, in addition to the Latitude data, we also have accumulating real-world data from observational studies that have been published both among people with viremia and people with history of adherence challenges. So UCSF, University of Mississippi, and the Ponce de Leon Center in Atlanta have published their experiences with initiating long-acting ART among people with viremia at initiation of cabrolpivirine, and they've found essentially between a 90 and 100% rate of viral suppression, with follow-up ranging from 3 months to a year in these studies. And then both here at UCSD, as well as at the SANA clinic at Prevention Point Philadelphia, which is a harm reduction services organization there. We've published results on uh, outcomes on long-acting cabrolpivirine among people who have history of difficulty with adherence and have again found very high rates of viral suppression within the first year of switching. but none of these studies look past the first year of follow-up. So the first project that I worked on this year with many of our colleagues in this division from the Owen Clinic, um, we're looking at the 96-week suppression rates with long-acting ART among people with adherence challenges and substance use disorders at the Owen Clinic. So previously, this group had published the 48-week outcomes, and we were extending that to look at whether these outcomes were durable over 96 weeks. So our goal was to describe outcomes on long-acting ART at 96 weeks among those who received care at Owen Clinic and have a history of difficulty with adherence to oral ART, and then to examine factors that might be associated with treatment failure. And this study was kind of designed as a real world observational study, mirroring the design of Latitude, but without the resources of a clinical trial. So the population included in the study were all people with HIV receiving care at Owen Clinic with documented adherence challenges to oral ART who initiated long-acting cabrolpivirine between November of 2021 and September of 2023. And then we looked at the 96-week outcomes, both describing this population including substance use and mental health history, and then used univariate and multivariate regression on both all treatment discontinuations, there were 14 treatment discontinuations, and then just on the 6 discontinuations that were due to virologic failure or loss to follow-up. And then just to note how we defined adherence challenges. So it was essentially the same as Latitude. It was either a poor response to oral ART, which was defined as detectable viremia in the prior 18 months, or loss to follow-up, which was no contact with an HIV provider for at least 6 months and non-adherence for at least 7 days. And then we looked at substance use within the prior year, either by looking at urine toxicology results, provider documentation, or on patient-reported outcome surveys that were collected as part of the CNIX program. So, our 96-week outcomes overall and stratified by substance use history showed that 77.4% of the cohort remained suppressed on long-acting ART at 96 weeks, and that among those with substance use, 69.2% remained suppressed on long-acting ART at 96 weeks. And there was not a statistically significant difference between the cohort with substance use versus the entire cohort. Um, the mean time to discontinuation in the cohort overall was 34 weeks, and about a third of participants had a late injection. So the reasons for virologic failure the reasons for discontinuation included 3 virologic failures with confirmed drug resistance mutations, and then 3 participants that were lost to follow-up, and then a variety of other reasons, 2 due to preference, either pain with injections or difficulty attending injection appointments. There were 3 adverse drug events that were reported. There was 1 death in the cohort, and then 2 discontinued for other reasons, one due to a desire to become pregnant and another due to insurance challenges. And then this also shows that most treatment discontinuations occurred in the first year. It's a Kaplan-Meier curve showing essentially the probability of continuing treatment or the time to failure. And the 3 stars indicate when the virologic failures occurred, which were all within the first year of treatment. Our univariate regression identified an association between meth use with the 6 virologic failures or loss to follow-up, and that viral suppression at switch was protective against cabrolpivirine discontinuation for any reason. And our multivariable regression did not show any significant independent predictors of treatment failure. And we've written up these results, and they're currently under review at the journal AIDS. So just some kind of key points and ideas for future directions of this work. So we showed that there are high rates of durable viral suppression on long-acting ART among people with adherence challenges, including those with substance use disorders. but this was a relatively small sample size, and there's also selection bias inherent to an observational study, though our study did seem to include a significant number of people with both substance use disorders and other significant barriers to engaging in treatment. Future work is needed in larger and more geographically diverse cohorts. And then some of the implementation challenges of expanding long-acting treatments to people with adherence challenges and people with substance use disorders include the significant program resources that are associated with administering long-acting treatments, and then also thinking about how to offer low barrier care, including in non-traditional settings outside of the kind of four walls of the clinic. And this was a modeling study that was published last year. Sorry, I know it's a bit of a busy slide, but essentially what this modeling study was looking at was different scenarios of implementing long-acting cabrolpivirine among people with persistent viremia and with adherence challenges to oral ART. And they looked at an immediate implementation of long-acting cabrolpivirine and found that it would avert nearly 4,000 deaths and lead to an increase in what they called virally suppressed person years of nearly 27,000. Whereas if we await the accumulation of trial data to expand long-acting ART in this population, the deaths averted will be much lower. So essentially arguing that we have a lot of the knowledge and tools we need to expand these treatments to people with adherence challenges, and that um, uh, there could be a substantial population benefit the sooner that we do so. So, segueing into my modeling work over the past year. So, I've been working on a project with a team from Johns Hopkins, including Sunil Solomon, Emily Kendall, and Allison McFall, under the primary mentorship of Dr. Natasha Martin, looking at the potential population impact of expanding long-acting ART among people who inject drugs in India. So there have been some modeling studies that have shown expanding long-acting ART in Africa has a substantial population benefit in terms of HIV incidence and mortality, but there's been very limited modeling work in general in low and middle income countries looking at long-acting ART, and there, to our knowledge, have not been any modeling studies published on long-acting ART among people who inject drugs. So Dr. Sunil Solomon was awarded an Avant-Garde Award to conduct a trial of long-acting ART for people who inject drugs in India, and there are three arms to the trial: an oral ART arm, a long-acting cabrolpivirine arm, and then cabrolpivirine plus lenacapavir arm. And our aim is to conduct preliminary modeling to examine the potential population impact of expanding long-acting ART among people who inject drugs on HIV incidence, HIV mortality, and drug resistance mutations in advance of the trial data. So we developed a deterministic compartmental model of HIV injection-related transmission and disease progression among people who inject drugs. And then we parameterized and calibrated the model to data from India that was collected by Dr. Solomon's research group. So we calibrated the model to an HIV prevalence among people who inject drugs in India of 41.5%, and then current ART uptake or current ART use of 31.9%, and a viral suppression rate of 54.4% among those currently using ART. And among those who initiate ART and then don't continue, the mean time to dropout is about a third of a year or 4 months. And the assumptions that we, some of the assumptions that we made in our model, or a 5% per year drug resistance mutation rate. So this was based on a meta-analysis that was done that looked at mutation rate to cabotegravir in both what they called switch suppressed studies and switch viremic studies, looking at people that were switched to long-acting either from with viral suppression or with viremia, and found that there was about a 5% annual mutation rate among those who switched to carbapenem by Remic. And the uptake of long-acting ART in our model we know the empiric data is unknown. We're not sure what uptake will be like in the real world, but survey data among people who inject drugs in India has indicated that 75% of people who inject drugs are very likely or willing to switch to long-acting ART. And then in terms of the viral suppression rate that we assumed in the model, again, this is unknown. So we simulated a range from the current 54% to 90%. And we modeled various scenarios. So the status quo scenario, which is continuing oral ART with no switch to long acting. And then we modeled an immediate switch to long acting ART with various rates of ART uptake and increase in viral suppression. So we modeled a 50% increase in ART uptake, which would lead to an ART coverage of 48%. Doubled ART uptake, which would lead to ART coverage rate among people who inject drugs of 64%, and then a 150% increase, which would lead to an ART coverage rate of 80%. And then across these scenarios, we modeled that the rate of viral suppression would increase from 54% to 70%. And when we talk about rate of viral suppression, it's not exactly the same as adherence, but it's uh, in some ways a surrogate for thinking about adherence to treatment. So here are some of the results from our model. So this is looking at the three scenarios of different rates of increase of ART coverage and showing that higher uptake of long-acting ART leads to greater reduction in HIV incidence. So the three different lines are the three different rates of increase. The middle line is essentially doubling ART coverage to 64%. And we see that this could potentially have HIV incidence over 5 years. And we also see that there are substantial differences in impact based on the differences in ART coverage. And similarly for mortality, HIV-related mortality, we see that um, uh, doubling long-acting ART or doubling ART coverage with the use of long-acting would could potentially have HIV-related mortality over 5 years. However, the accumulation of drug resistance mutations is significant. So in the scenario of doubling ART coverage, which is the orange bars, within 5 years, we could potentially see 14% rate of virologic failure due to drug resistance. And then we looked at um, uh, both viral suppression and increased ART coverage, and essentially found that the greatest impact is driven by the degree of increase in ART uptake and not the increased proportion virally suppressed. So, kind of just to walk through this slide, on the x-axis is the proportion that are virally suppressed. So, starting at 54% and going up to 90%. And then along the y-axis is the increase of enrollment in ART. And then the color map essentially shows the decline or the HIV incidence rate. So yellow is a higher rate of HIV incidence and blue is a lower rate of HIV incidence and green is in the middle. And so going across the x-axis, we see that there's some change with an increase in the proportion that are virally suppressed, but not a very significant change. Whereas going up the y-axis, we see a much more significant change in the incidence rate with increased enrollment in ART. And then obviously the greatest reduction in incidences from both an increase in the proportion virally suppressed and an increase in the ART enrollment rate. But essentially, what we found is that the greatest impact is driven by the degree to which long-acting ART could increase ART uptake. So we found through our modeling that long-acting ART could have a substantial impact on reducing HIV incidence and mortality among people who inject drugs in India, and that a key driver of impact is how much ART uptake increases with long-acting ART. However, we know that drug resistance, both treatment emergent drug resistance and transmitted drug resistance, are real concerns. And in terms of future directions, modeling can be useful in identifying the potential impact, and real world data is needed to support these findings and also to better parameterize our models. And then just one note on kind of this modeling work. This in part is uh, due to the mentorship of Dr. Solomon, who over the past 7 years ran Project Accelerate, which was an HIV care model in India that was due to be handed over to the Indian government in December of 2025. And then in January and February of 2025, their PEPFAR funding was uh, essentially entirely cut and the program had to close. Um, and for those who haven't seen, I would encourage you to read his piece that was published in Clinical Infectious Diseases earlier this year about the human impact of the shuttering of this program. Um, and this impacts the ability of the trial to go forward and also just more generally the availability of long-acting regimens and then HIV treatment in general on a global scale, which I know is something that many people here have been thinking about. So thank you for listening today. Thank you to the Hope T32, which has funded me over the past year, and then to the mentorship of Dr. Martin and to all of the collaborators that I've worked with over the past year. That's
Lily, thank you so much. That was a great talk. It's been really nice to see what you've been up to. Um, I will open it up to the group. It looks like Natasha has her hand up.
Hi, Lily. Great job, of course. A nice, very nice presentation. And it's so nice to see kind of the different threads coming together across your different projects related to long acting. Um, I was thinking about, your main finding for the India modeling, that in places like in India where AOT coverage is very low among people who inject drugs, then the impact of long acting could be very substantial if it increases that uptake. So I sort of had two questions. One was, do we have data from India, but also from other settings, and maybe people on this call know, in terms of willingness to go on long acting compared to oral and just that sort of choice, and um, whether people have concerns about going on these long acting medications, and do we think that it could be quite substantial in terms of the increased willingness to go on these long acting treatments compared to oral? And then my second question is, a reflection about the generalizability or lack thereof of the India setting, right? So in places like the US, where maybe we have higher uptake, then the impact of long acting could be driven more by changes in viral suppression and adherence, right? Which is a little bit different than what you found in India, where clearly uptake is poor. So if it could increase that, that could have a huge impact. Whereas here, if we have relatively, better uptake, then that I would expect that impact could be driven more by the differences in adherence and viral suppression. Sorry. So I guess that was just more of a point that it would be interesting to look at user modeling to look at whether that conclusion actually differs when you're in settings that already have high levels of coverage, and teasing that out and trying to understand, locally what the impact could be would be great. Okay.
Yeah, I think to the first question, I mean, I know there are some kind of experts on long-acting treatments here on the call who probably know much more than I do, but there have been some surveys that have been done about preference for long-acting treatments, including there was a survey done from Boston Medical Center, specifically among people who use drugs, and looking at kind of barriers and facilitators of uptake of long-acting ART. And I think kind of across the board, there has been very strong interest and very strong acceptance of long-acting ART. And I know in India, the as part of the respondent-driven sampling that this group has done, they collected data on long-acting ART, and they found that about 75% or more than 75% of people currently on oral ART are interested in switching to long-acting, and that um, uh, about nearly 70% of people that aren't on ART currently would be interested in initiating long-acting ART if it were made available to them. So it seems like there's very strong interest. I don't know. I'd be interested to hear. I know there are a lot of people on this call who have a lot of experiences with long-acting, whether that holds up in people's experiences as well.
The other Dr. Martin.
Thank you, Dr. Blumenthal. Uh, well, Lily gave the perfect academic answer there, so I'm just going to give the total opposite, which is the anecdotal report. And I will say, with the direct consumer advertising in the US, patients were aware very quickly about injectable therapy, and they all came in saying that they thought it was better than their current regimen, which, for the majority is not true. It's equivalent. Um, and so I think people are very keen for uptake of new therapy in the US. It'd be interesting to compare to other settings, though, and to sort of see how quick the uptake in interest is without that kind of direct consumer advertising by ViiV. The second thing is, I just want to re-emphasize how critical this work is, because we are not at the destination of these therapies, right? I think in whatever it's going to be, like 5 or 6 years, 6 monthly injectable regimens, and I think that will be, critically important for us to be ready for when that's here to maximize its impact, because there's loads of people who are kind of like, oh yeah, I really want to do injectable 8 week. I'm not quite bought in, but literally every single person would want a 6 monthly injectable. In my opinion, everyone would want it.
Even your people who inject drugs or people with substance use.
Definitely, some of those people are hyper aware of these things, and they're very interested in them. So that's my anecdotal opinion.
I'll get to Anik. I want to anecdote for one
Yeah,
second.
thinking Laura.
And this is on the prep side. So just in terms of what people want, I do think people who inject drugs, um, they're and this was our experience from P4, which hopefully people will hear about soon. That was the use of lenacapavir for HIV prevention in people who inject drugs. There definitely were some people who were not keen on an injection. And so as Tom's saying, it's for everyone. I think he's being a little bit hyperbolic. It's not for everyone. There are definitely going to be people who don't want it because of the connotation, the injection. They inject in certain places for certain reasons. I think the much bigger issue, which I don't think you talked about as much here, is access and how you actually get these people. I mean, and Tom and Laura and everyone else involved in the low barrier care that they're trying to do, it's a Herculean effort to make it happen. But meeting people where they're at is going to be so important as well. So you can have the long-acting injectables, and that could be great for people who inject drugs. But can they actually get them? Will their insurances cover them? All of those things, have to be factored in. Sorry, that was like an explosion of thoughts that I had that I wanted to say, and I popped myself in front of Anik because I just wanted to respond to Tom's. I don't think it's everyone, and I do think there's going to be some individual choice. And I know Tom's going to say he didn't mean everyone, or maybe he's not going to say anything. Anik, go ahead.
No, that's cool, Jill. Feel free to pop yourself wherever. But I actually was wondering if Laura had something to say about that because my comment is obviously not, I don't have patience, as you know. So I just wanted to give Laura a chance if she wanted to share her thoughts on preferences.
Yeah, and no, thank you. And I think because these haven't been available and there hasn't been great uptake, I think we don't have that real world data yet. But I want to give a plug for Nicole Kelly, who under the mentorship of Laramie Smith, has a next gen CFAR award to study just this. She's doing some focus groups with people who inject opioids. And asking about preferences related to not only long-acting injectables for HIV, but also for opioid use disorder, and then also looking at perceptions amongst providers. So I think we'll have some data at least from the Owen Clinic soon to answer maybe some of these questions.
Amazing. I guess one of the points I had was more around, that's not my question, but was more around the logistics of it, like the whole like fridge and all of that. I mean, is that going to be a massive issue? I mean, I don't want to say that it's not possible, but I guess logistically it's more difficult, right,
Well,
than oral prep.
yes, logistically, yes. But I would say, probably the upfront costs and kind of personnel power to make it work. Down the road, though, we're gonna see less emergency department visits and hospitalizations and urgent care visits and everything else, or treatments of OIs. So I think upfront, yes, there'll probably be a lot more cost, but I think the long-term implications are enormous.
And Lily can show us that. And here's my question, Lily. That was a beautiful presentation, and it's so nice to see you in full modeling mode because the last time I saw you was in the class like 3 years ago or something. So I'm like, wow, those graphs are amazing. I don't know how she made them. But I guess my question was around the resistance. Um, the numbers were a bit like, ooh, that's scary kind of thing. And when you showed the graph about percent virally suppressed versus proportion on long acting and proportion on long acting being the driver of impact. But I was wondering, well, in that case, it's also the driver of resistance, right? If we're on this side of the graph, what would be, how would it look at population level in terms of resistance? And so I wondered if you could tell us a little bit more about your resistance findings.
Yeah, I think that's a really important point. And I'm also curious. I know there are many people on this call who probably have a lot more informed thoughts about the risk of resistance. And I'm curious to hear what others think as well. Definitely, the rate of resistance is driven by the degree of ART uptake. And so with higher rates of uptake, there are higher rates of resistance. Um, and I think that there are many drugs in trial with different mechanisms of action that could potentially be treatment options for people that develop resistance to CAB and rilpivirine. But I don't know how we weigh that against the population impact of potentially having, I don't a 14% prevalence of cabotegravir resistance, which is pretty concerning. So I think it definitely is a real concern. One of the like attenuating factors is potentially that there are new drugs down the line that could be made available. But I'm curious to hear what other people think as well.
Can I comment, really?
Yeah, that would be great.
No, I just, I think, I think the question is kind of twofold. One is what is the impact of potentially underlying resistance on the success, right? But also what happens when a population that's at higher risk of potentially falling out of care or not consistently receiving their injections, what is their risk of resistance? And I think like from our kind of anecdotal experience, we don't have a great grasp on like particularly when people fall out of care, don't show up on time for their injections. What is the kind of threshold for when resistance might happen and things like that? And I think it's really interesting to study the three arms, that they have an arm that includes lenacapavir with cabrolpivirine along with cabrolpivirine alone when they actually do the intervention. And I think that's one question, is like adding the lenacapavir, does that potentially increase the robustness of the regimen, but also if someone's late for their injections, potentially protect against resistance? And those are questions that I think we have when we're using injectables in what might be a higher risk population of patients. So, hopefully there's some answers from that. But I think the other thing to consider is, like, if we do include something like lenacapavir, or we're risking INSTI resistance, future injectable regimens a lot of them are gonna include lenacapavir, including Q6 month regimens. And then they also include INSTIs, but the question will be too, what is the impact on the availability of future injectable regimens if resistance does happen? Because they will include often INSTIs and capsid inhibitors. So just kind of my thoughts on that.
Andy. Oh, sorry, Lily, did you want to respond?
Oh, no, that's okay.
Okay. Go ahead, Andy.
Yeah, thanks, Lily. That was incredible. Thanks. So yeah, Katie and I both have computers going, and that caused an echo. What comes to mind is two groups, and I'll be a little bit supportive of Dr. Martin number two and the everybody thing. Um, I used to be of the thinking when it came to ART and long acting, there's so many people that are taking other medications, whether it be polypharmacy for people who are aging or whatever else you have. Um, there's a hierarchy of importance in medications that, uh, gosh, my atorvastatin, if I miss that one day, that's not really going to mess with anything. But I do know that it's really important that I get my ART in. So my my past thoughts were, if you're taking pills for something on a daily basis, why bother with injectables? Because you're just taking pills anyway. Well, it loosens the burden a lot to take your art out of the mix, because if you're on 6 month therapy, for example, even the 2 month, uh, you you know you're covered. You know you've got your very important life-saving medications in. And while no clinician on this planet we live on is going to say, yeah, don't worry about taking your other medications, but I just think that both for substance use disorder, people that deal with that takes a worry off of them as far as missing medication. And I think it works for the aging population, polypharmacy population, as well as the population that is, commonly thought of by drug companies to be unreliable. And I know that because we've fought the fight. Jeff Taylor and I, we belong to a group that meets with pharma, and it was a struggle to try and get them to come around and recognize that there can be some successful studies that include people that are not necessarily the dictionary definition of who you would want as a study participant.
Thank you for that advocacy. I know that, yeah, it's really important to have data that includes data like such as the Latitude study. I think it can have a really, really big impact. And having more diverse inclusion in trials is really important. I was going to say something on resistance, but I see Anik and Tom both have comments, so
Well, I
maybe.
was just going to make one comment still back to the many versus all. And maybe I'm beating a dead horse here. There is a reason that, I don't know, and Lucas can correct me, right now, at least in our clinic, about 500 people are using cabrolpivirine of 3,500. And I'm sure there are, I'm going to make up a number, 400 to 500 that wouldn't qualify for various reasons. There are a lot of people who still don't want to do it. They're very content with their medication. And I have the same people say, why would I switch to injectable and come in, 6 times a year if I'm taking all these other meds anyway? So, this is why we have patient-centered conversations. Everyone feels differently. The person who says, one less medication is easier for me. There's another person on the same side saying, I don't see how one less medication makes a difference for me. And so obviously that's why we have choice. And fortunately, we used to live in a country where there seemed to be a lot of choice. I hope we will continue to have that. And I do agree that once we have different regimen options, I think the Q2 months is a barrier for a lot of people. Although I just saw Dave's hand go up, and I realized that people who use substances may be coming in for other reasons, and that's all wonderful. Again, just making the point that everyone is, there are differences in people, and that's why we will always have oral options, right? All right, I think Anik was next.
Yeah, mine was just modeling questioning because I assume that the way that resistance is modeled now is just like adding a rate of developing resistance among those who are virally unsuppressed. But I wonder if that leads to an underestimation to some extent, given that maybe those are gonna be then I've forgotten the word strain, like that HIV strain or whatever is then gonna be transmitted more like I don't know the biology anymore, but are those more likely to be transmitted? And so would we have an amplification of resistance being transmitted that we're not accounting for right now?
Actually, the way that we've developed the model right now, we do account for transmitted resistance in
Okay,
addition
that's
to
awesome.
acquiring resistance, like treatment emergent, I guess acquiring resistance on treatment. But yeah, I mean, Lucas's point is really well taken. And I think that we don't really know, for people on cabrylpivirine. I think we've more modeled the scenario of people on cabrylpivirine rather than cabrylpivirine plus lenacapavir, and we don't really know how lenacapavir may attenuate some of the resistance that can develop. And so, yeah, I think that there's still quite a bit that's unknown about resistance in general.
Thank you.
Tom was next.
Yeah, just very quickly, and it's in response to this question about resistance. I know that some of the ultra long formulations that are being tested in mice at the moment, the development in the pharmaceutical industry regarding this is incredible because they're getting these 6-month therapeutic levels of dolutegravir with a very short pharmaceutical tail after that. And so I think this is an issue that is going to be there, but hopefully will be minimized by this very clever ultra long acting drug design to minimize the duration of the pharmaceutical tail, which is really when the risk comes of transmission of resistance to other people, development and transmission to other people. Because if we minimize that duration to say 1 month or 6 weeks, the chance of transmission, development of resistance and transmission is small. After that, wild type will supersede, and that will be the transmitted resistance most likely. So I have hope for the future.
Dr. Grillotti.
My hand did go up during your comment, Jill. I think I presented this, but we did an implementation study a while back and asked folks in various stages of their substance use journey and what their opinions on long acting were. And it very much, as you said, like some people are into it, some people are not. So it's definitely a tool in the toolbox, not a one size fits all approach. And then just a general comment, I hear a lot of discussion about the biology of HIV and HIV transmission here, but not as much about the biology of substance use and addiction and how that influences people's choices, decisions, behavior, all sorts of things that I think are very relevant and ought to be accommodated in models and other and the development of approaches to treat folks, whether it be, in the clinic or outside the clinic.
Yeah, I think those are really important points. And I think that it's important to recognize, and I think that long-acting treatments are an option, that or a tool that should be kind of made available among the treatments that are offered, but not necessarily the a solution for everyone. And I see that Dr. Promer's put a couple of comments in the chat as well about kind of direct to consumer advertising about injectables and how these are made to seem superior to currently available regimens. I mean, I think probably the uh, smarter pharmacologists on this call would think that cabrolpivirine is probably not superior and potentially somewhat inferior to something like Biktarvy. So definitely not the kind of solution for everyone. But I think like one of the findings from the Latitude study was that it included people that like really had significant difficulty adhering to oral therapies, and that these are people who could potentially really benefit from other options. So I don't think that I think probably we all agree that not everyone, even Dr. Tom Martin, that not everyone will want a long-acting injectable, but they're a really important option, and that access for some of the people who could potentially benefit most has not been made available.
I'm just keeping an eye on the time, and I'm just going to go to Aaron since he hasn't been able to share yet. And Dave, I don't know if your hand's still up, you're responding, but Anik, we can come back to you. Go ahead, Aaron.
Thank you. I was getting ready to type out a long message, and then I was like, wait, it'll be quicker if I just speak. Thank you for the presentation. My headspace is thinking a lot this morning on this sort of unmeasured psychological aspect of long-acting injectable medications. I've talked with Lucas about this several times with patients, anecdotal data. I've had patients who, for years and years and years, were never able to virally suppress, and they struggled with appointment adherence and sort of self-care. And then when they finally suppressed on long-acting injectables, they show up for all their appointments. They've stable housing, but what the first thing that came was getting undetectable with the long-acting injectables. Like that was this sort of psychological cascade began after that. I also have other patients too, to Dr. Blumenthal's point, who don't want to get on long-acting injectables, who I think there is a psychological aspect of HIV stigma, the stigma of substance use disorder in and of itself, and perhaps the combination of the two. People have a sense of failure. Their self-image is one that maybe they don't feel worthy. They don't subconsciously maybe don't want to get undetectable or healthy, like they don't feel worthy of that kind of progress or care. There's a lot of self-destructive patterns in these individuals, and so I don't know if there's a lot of data, or if not, hopefully in the future, there should be looking at sort of the psychological impact of long-acting injectables for these patients, both as a barrier for accessing them, and then also as I don't know, a secondary endpoint or whatever with it. I'm thinking more about the psychological component of this, less than the resistance data, less than the efficacy of viral load suppression, which is great. Thank you.
Thanks, Aaron. Lily, last comment since it's 9.
Oh, I just wanted to say thank you all for listening and for this discussion. It's really great to learn from all of your ideas, and also very grateful for the mentorship that I've had over the last year to be able to look into some of these questions.
And Natasha, thank you for that comment back to Dave. And I hope that's going to be your next study with Dr. Garlotti. I'll leave it at that. Thanks everyone so much. Lily, this was great. Obviously,
Great job,
very,
Lily.
yeah, thought-provoking, and led to a wonderful, robust discussion. I wish all high rounds were like this. So anyway, thanks, Lily. Great job, everyone. Natasha, great mentoring. Everyone, wonderful to be here. Thank you. See you
Have a
next
great week.
week.